to, again, thank everybody who's joined us. I know a few more people kind of joined in as this presentation is going. I'd like to introduce Dr. Richard Madonna. Dr. Madonna, please, if you can unmute yourself. He is the clinical chairman, he's the chairman of the Department of Clinical Education, Director of Continuing Education. Dr. Madonna?
Thank you, Betsy. Can you hear me?
I hear you loud and clear.
Thank you so much. First of all, I want to thank Allergan for their support, and specifically Mark Risher. Mark and I have been friends for many years, and I appreciate all the support he gives us at the college and for his friendship, quite frankly. And we do appreciate Allergan's support for the program today. So let's just jump right in. This is, as many of you know, this is the third time we're doing this. And at our second webinar, three of our faculty have been asked to return for round 3 because they did such a wonderful job the first time around, and the areas that they're covering, I think, are changing so rapidly that we felt it appropriate that we bring them back and add on to what they provided the first time. And so I'm really excited to hear, because everything is changing so rapidly. Before we jump in, what I'm going to do this time is just introduce them before they speak rather than introduce everyone at the start to save a little time. And we ask you to put your questions in the Q&A box and anything else in the chat box so we can monitor the Q&A, and we'll go from there. So first up will be Dr. Ann Beaton. Dr. Beaton is an associate professor at the college. She's our non-optometrist on the group, but has a PhD from Cornell. You might remember last time, if you were on, that Dr. Beaton said that, she feels as the non-optometrist, she's the nerdy girl invited to the prom. And as a couple of you said to me that I should take Dr. Beaton to the prom, I'm happy to take Dr. Beaton to the prom the next time the prom actually happens. So without further ado, I'm going to hand this over to Dr. Ann Beaton.
Okay, here I am. Okay. Betsy, can I share now?
Yes, you can. Go for it.
Okay. All right, let's start at the beginning. Okay. Okay, here we are. So good afternoon. Thanks, Rich. Thanks for Betsy for asking me back. And thanks for inviting Nerdy Virology Girl back for a second date. So I thought I'd start off by updating you on some of the topics from the last CE on testing, treatment, and prevention, and get to where we are in vaccines and new treatments, including monoclonal antibodies. So let's start off with testing, and the question is, where are we? So last time we talked about the test for viral RNA detection, and we talked about the RT-qPCR test, which is considered the gold standard, because even though it isn't perfect, it is still the most accurate testing available for viruses. The downside of PCR testing is that it takes special equipment, it takes trained personnel, and it makes it hard to scale up to the numbers that we really need. And one of the big problems is that tests typically don't come back for a couple of days. The Abbott Laboratories ID Now test returns results in about 15 minutes. We talked about this last time as well. Remember that it too has limitations because it requires special equipment and requires training, and limited still by the availability and quality of the reagents that are necessary to carry it out. Now, this is the test that the White House is using now to test its staff, and if you really want to see how it works, you can actually go onto the New York Times website where they have an animation showing you how the test is performed. The latest in this genre of testing is called Sherlock, a very cute name that's kind of an acronym for Specific High Sensitivity Enzymatic Reporter Unlocking. And this test is based on the gene editing technique called CRISPR, which is a very powerful and to some people scary gene editing technology. The Sherlock COVID testing has been given emergency use authorization from the FDA to detect SARS-CoV-2 virus. The test is carried out with RNA, just like the RT-PCR tests are, purified from patient samples. And ultimately results can be read, as you can see here, by using this kind of dipstick thing where they stick something into a, the reaction and they get lines. So you can see in the control, there's nothing. The negative control gives you a certain outcome, and then the positive control, a different one. It doesn't require elaborate instrumentation. It can use an isothermal heat block or even a water bath. And I found this very interesting. They're actually using, what they use, those sous vide that are used for cooking and keeping, cooking meats and things at a certain temperature. So they can use these sous vide immersion cookers to actually carry out the tests. And an important innovation that goes along with this technique is something they call stop or Sherlock testing in one pot. And here what's important is that they don't have to transfer the samples from one tube to another, and it can be done in one temperature and one tube, and it would be, as a result, very suitable for point of care testing. This technique detected infection with 97% sensitivity, 100% specificity, and can even be used on saliva, and that's really good because it averts the necessity of using swabs, which seem to be in short supply, and of also having to poke those swabs way up into, close to, people's brains. They feel like their brains have been touched by those swabs because they stick them so far up in the nasopharyngeal cavity. Another interesting point is the team that has developed this is openly and willingly sharing the reagents and the protocol, and what they're hoping is that other people will try it and come up with new and improved versions as a result of kind of community sourcing and using the test. In terms of testing, something that's very new that's come out and is a new and important addition is antigen detection testing. So again, antigen tests are similar to PCR in purpose because both detect new cases of COVID-19, but antigen tests are easier to carry out and give quicker results. So while the PCR tests look for evidence of viral RNA, antigen tests are looking for fragments of viral surface proteins as a marker for infection. Now, antigen tests are quick. They can diagnose infection in just a couple of minutes. They don't require expensive equipment or extensive training. And so in theory, a reliable antigen test is easy to scale up and can then be used at home or at point of care locations again. This particular approved test does require special equipment called SOFIA machines, but the good news is that something like 40,000 doctors already have these in their offices because they're used to test for both strep throat and for flu. And each test will only cost on the order of about $5 with the results available in a couple of minutes. And back at the end of April, Dr. Birx from the White House said we have to be able to detect antigen rather than constantly trying to detect the actual live virus. And Scott Gottlieb, former head of the FDA, said a new antigen test to rapidly screen people is a real game changer. So hopefully this, will really move us into another better direction in terms of testing. Now these tests are only 85% sensitive, meaning that positive results are highly accurate, but result in a high number of false negatives. So a negative result won't necessarily rule out disease, and they may need to be confirmed with the PCR test, particularly in patients who have the symptoms that we all have become aware of prior to making treatment decisions or to prevent, possible further outbreaks. In terms of serological tests, we also discussed these last time, and these of course detect whether you were infected with the virus and have made antibodies to it. So there are basically two different genres of these tests. There's these kind of lateral flow tests, which kind of look like a pregnancy test. You put a drop of blood on it, it migrates along this strip, and if you've recently become infected, you'll have both IgM, you'll first have IgM, later you'll only have IgG. And then on the right, what you see are enzyme-linked immunosorbent assay type tests where you put things in these little well plates, and you can either get a colorimetric readout, as you see here in this picture, or sometimes they actually have to take these things and put them inside an ELISA reader, which is read at 450 nanometers. Now, both of these methods are quick, but they have a less than optimal sensitivity. That is, they may be positive when in fact someone is actually negative, which can be highly problematic, and I'm going to discuss more about sensitivity and selectivity now. Okay, so I thought I would digress just for a minute to talk about this because there's been a lot of discussion about the difference between specificity and selectivity. So specificity is the ability of a test to correctly identify those with the disease. So that's the true positive rate, as you see here. High specificity tests are good at catching cases of the disease, but come with a fairly high rate of false positives. And there's a mnemonic if you want to remember how this works, right? So specificity is positive, ruling in disease. On the flip side, sensitivity is a highly sensitive test. If it's negative, it rules out disease. So again, sensitivity, negative, ruling out. And here, in terms of sensitivity, you want as few false positives as possible. Well, how does this apply to the coronavirus testing? Okay, so it's important for disease tests to be highly specific so that if the test is positive, you know that the person is infected. This means there'll be as few false negatives as possible. And although you may end up with a number of false positives, it means that you might end up quarantining someone who doesn't need to be for a few days. And that's better than letting someone out, who has the disease and tested negative. In terms of antibody or the serology test, sensitivity is more important because positive tests indicate prior disease. And you want as few false positives as possible because people who test positive may feel confident that they have already had the disease and may feel a false sense of security and invulnerability and feel that they have this so-called immunity passport and can go out and do everything that they want. If you want to hear more about the testing, and I know this sounds kind of funny, but actually John Oliver on Last Week Tonight, and you don't have to even have HBO to watch this, you can actually pick it up on YouTube. He did a great dissection, really very factually accurate on diagnostic testing. And don't be offended, there's kind of a lot of salty language there, but the content is really, very good. Okay. So, and he says this in his thing, and people who are, experts in the area really feel like the antibody testing is the wild, wild west. And the reason for that is that there are a lot of antibody tests out there, and up to very recently, the testing has, the FDA gave emergency use authorization for tests without their being validated. Now the FDA is finally clamping down and requiring companies who want to market these tests to submit data within a short period of time to get authorization. So just to remind you, low sensitivity tests put people at risk who test as false positives. Okay, so in terms of treatments, where are we? So again, I showed this last time too. This information comes from the Milken Institute, which has these very nice graphics about the different areas that are being looked into in terms of treatment. So if you look, you can see that, antibodies play a big role, antivirals, and then there's a lot of other smattering of other things, and including this, kind of unknown area here, where people are trying to, find treatments for COVID-19. So let's talk about some of the treatments that we talked about last time. And one of the first ones we talked about was the use of chloroquine phosphate and hydroxychloroquine sulfate. So a study that was just published in the New England Journal of Medicine on May 7th included 1,400 patients who were admitted to a New York City hospital, 59% of whom were treated with hydroxychloroquine. The patients who were selected were more severely ill, and in this observational study, their conclusion was that hydroxychloroquine administration was not associated with either a greatly lowered or an increased risk of the composite endpoint of intubation or death. Now, let me emphasize that this was not a randomized controlled trial. There is, however, another study that is going on. This study is called PATCH. I love the acronym, Prevention and Treatment of COVID-19 with Hydroxychloroquine. And this is a randomized controlled trial, and it has several different cohorts. The first one is a double-blind placebo-controlled trial, high dose as a treatment for homebound patients. And here they're looking at the median release from quarantine. The second cohort is a randomized study testing different doses in hospitalized patients. And here they're looking at, when the hospitalized patients are being discharged, how many days. And the third cohort is a double-blind placebo trial of low dose as a preventative, as a prophylactic, basically, in healthcare workers. And they're looking for the rate of COVID-19 infections at the end of 2 months. In terms of antivirals, the antiviral just approved to treat COVID is remdesivir, and this was originally formulated as a general antiviral and later tested in Ebola patients in which it really didn't perform all that well. So what remdesivir does is it is basically a nucleotide analog, and it gets incorporated instead of adenine, and where it is incorporated, it halts RNA synthesis. In a study done in China, they did not show statistically significant clinical benefits, but in the NIH clinical trial showed that remdesivir does accelerate recovery better than placebo with a 31% faster time to recovery. Now, the thing is that remdesivir actually, its job is to interrupt viral replication. So it would be most efficacious if it could be used in patients during the first week of COVID-19 when virus is replicating to high numbers. But often patients are not that sick in the first week and they don't start to really decompensate until the second week. And in fact, in the second week, the virus may be done replicating. So researchers conducting NIAID, the National Institute of Allergies and Infectious Disease trial of the drug, are now testing it in combination with, an anti-inflammatory arthritis drug, whose brand name is Olumiant. And because remdesivir is administered by intravenous, it's less useful to treat patients in the first week of disease, right? Because they're home, not in the hospital. So Gilead is trying to develop an inhalation method of administration for it so that people can suck it into their respiratory tracts while they're home. And they're also trying to develop a prefilled syringe that can be prescribed for patients who are at home in the first week. And they may find better outcomes then because they'll actually be interrupting viral replication. Another antiviral treatment that is being looked at right now is what we call the combination triple therapy. So this consists of treatment with drugs called protease inhibitors. Here where they're using lopinavir, ritonavir, which is a combination drug given for HIV called, in one formulation, Kaletra. The second drug is ribavirin, which is a guanine nucleotide analog, and interferon beta 1b. So the lopinavir, ritonavir are protease inhibitors that prevent the SARS-CoV-2 protease from processing viral proteins. So the coronavirus genome is this long 30,000 nucleotide genome. It produces some proteins that are very long, and in order for those proteins to be active, they have to be cut. So where you see these red triangles and the yellow triangles, these are what we call polyproteins, essentially proteins that are joined together that have to be activated by being cut by the viral protease. And so what the protease inhibitors do is prevent that. And if you prevent the cutting of these polyproteins, you can't get the proteins that actually do the work, and you inhibit virus replication. And this is exactly the same way that the protease inhibitors that are used to treat HIV, how they work. Ribavirin is a guanine nucleotide that has broad antiviral activity, and it's used against many RNA and DNA viruses. And the third component, interferon beta 1b, is a cytokine. It's sometimes called, in its generic form, beta-seron. It's used to treat MS, and it enhances the activation of cytotoxic CD8 T cells and also induces the synthesis of several key viral mediators. Okay. So they actually have carried out a phase 2 trial in Hong Kong. This was published in The Lancet in the beginning of May. And compared to a control group, this early antiviral therapy was found to be safe, superior in alleviating symptoms. So people had symptoms for 4 days instead of 8. It shortened the duration of viral shedding down from 12 days down to 7. And that's really important because that makes patients less contagious, right? So less able to spread, and shorten their hospital days from 2 weeks down to 9 days. Okay. As I mentioned before, patients infected with SARS-CoV-2 often do well in the first week of infection when there's a lot of virus replication going on, and then suddenly go down in the second week when there's actually very little virus replication. So it's widely thought that the cause for the decompensation in the second week is the result of a cytokine storm, that is an overly exuberant immune response that is now doing the damage instead of helping. And here you see kind of the whole process. Here's the virus binding to the ACE2 receptor. It uncoats, the viral genome gets released, it gets translated, viral proteins that need to be cleaved are cleaved, you make new virus particles. But now you have here, we're showing immune cells recognizing this as foreign, and you're getting activation of this immune response. Among the treatments being used to treat this overly exuberant immune response is an anti-IL-6. IL-6 is shown here. This is a monoclonal antibody called Actemra or tocilizumab that is ordinarily used for various inflammatory diseases like rheumatoid arthritis and giant cell arteritis. Another approach that's similar, that's hoping to tame this cytokine storm, is to target complement, right? So complement are a bunch of proteins that come from the liver that are involved in both the innate and the adaptive immune response. And what this is trying to do is trying to tame the immune damage, target complement, and because it instigates a lot of the pro-inflammatory response that may contribute to this maladaptive inflammatory response seen in some patients with severe COVID. So you can see that there are lots of other targets, even though Actemra is the one that's been tried against IL-6, you can see that there are many other cytokine targets that are available to try the drugs against. Okay, other avenues for treatment include antibody therapies. So just to remind you, these are passive. This is giving passive immunity in which preformed antibodies are given to patients. Now this provides immediate protection from the virus, but the protection's not long lasting, and it doesn't establish memory to protect from subsequent infections. Much like antivirals, antibodies also work better best either prophylactically or early, although some reports from China suggest that therapy may also work during the later phases when acute respiratory distress is already established. Now, plasma not serum is used. Actually, my slide is a little off there. So there are lots of clotting factors present, and since there's been a lot of blood clotting pathologies, particularly in the second week of COVID-19, it's really important to monitor these patients very carefully. The second type of antibody therapy is using monoclonal antibodies. Now, to avoid some of the side effects of antibody therapy, it's important to identify antibodies that are neutralizing, that is those that actually prevent infections, and that is what's hoped to be accomplished through the development of these antivirus monoclonal antibodies. Monoclonal antibodies are engineered, man-made antibodies that act like human antibodies and are designed to specifically target a certain antigen, such as I'm showing here. So you can see that here you see monoclonal antibody, right? That is, if this is the cell, this might be targeting the receptor, but could also instead bind to the virus and prevent it from binding to its cognate receptor. Monoclonal antibodies are by no means new drugs. In fact, you heard at the beginning how Humira, is a drug that AbbVie is selling. It is in fact the world's best-selling drug. It was the world's best-selling drug in 2018. It's used for the treatment of rheumatoid arthritis and other inflammatory diseases. Monoclonals are also being used to treat certain types of cancer very successfully. These are the so-called checkpoint inhibitors, which you see ads for on TV all the time. And there are many monoclonals in development to treat COVID, including one that cross-neutralizes both SARS-CoV and SARS-CoV-2 through a yet unknown mechanism that is different from receptor binding interference. Now, these antibodies are very useful as a bridge until we have a vaccine. They're useful in prophylaxis, say, of healthcare workers and other exposed persons to prevent infection, and ultimately in the treatment of infected patients. Monoclonal antibodies are particularly useful in preventing disease in populations where vaccine responses are usually poor, such as with immunocompromised individuals, the very young, and the very old. Many companies are starting to do clinical trials with antibodies. As one example, a local company called Regeneron, local to the New York area, has a track record with an Ebola monoclonal that took 9 months from initiating the project to starting human trials. And with SARS COVID-2, they hope to break that record going from project initiation to clinical within 5 months. Okay, in terms of vaccines, where are we? So again, this is from the Milken Institute. This is showing how many different types of vaccines are being developed, and I will highlight just a few of them. Oops, wrong way. All right, so the first one is using adenovirus as a vector to bring a piece of DNA into a cell. So here you see an adenovirus. It's been modified and genetically engineered to incorporate the spike protein so that when this viral vector infects a cell, the cell will then express the spike protein. In a person, your immune system will recognize it as being foreign, and you will start to produce antibodies such that if you are ever exposed to the virus, you will not get it, right? The next one I'm mentioning to you is a very similar approach, just using a different virus as a vector, and that virus is AAV, and I'm talking about this one because this is the same vector that's used for Luxturna, which is the one that's used to treat Leber's congenital amaurosis. The most different vaccine among all the ones that are being talked about so far is Moderna's mRNA 1273 vaccine. And this is an mRNA vaccine. In fact, it's really mode RNA, just that the word happens to work together to make Moderna, so they call it Moderna. So this is a very new vaccine technology. No vaccines using it have been approved yet. The idea is to engineer a messenger RNA encoding a spike protein, the SARS-CoV-2 spike protein, and then deliver that messenger RNA to cells where it can be translated into coronavirus spike protein. So here you see a particle, it gets inside a cell, it reduces its RNA, it releases its RNA, that RNA gets translated on host cell ribosomes, right? The cell expresses the spike protein on its surface, and then your immune system recognizes it being foreign and starts to produce, hopefully, both cell-mediated and humoral antibody. A 45-patient phase 1 trial was begun in Seattle and a larger one at Emory. And the biggest hurdle for messenger RNA vaccine is drug delivery from the injection site into the cell cytoplasm. And this has been an intense area of research, and what they've settled on to use so far, and what you see here is a kind of a lipid membrane. This is what they call a lipid nanoparticle. And these are so far leading the way in terms of these mRNA vaccines. Moderna has filed for investigational new drug permission from the FDA, to go to phase 2 trials and sign a development agreement already to scale up vaccine production to 1 billion doses per year. And they're working along with BARDA, the Biomedical Advanced Research and Development Authority, to obtain funding. One potential problem with every vaccine project that vaccine project will be on the lookout for is something called antibody-dependent enhancement of disease. This is the possibility that a vaccine, instead of actually preventing infection, will actually make the disease worse. It happens when virus-specific antibodies either enhance the entry or sometimes enhance the replication of the virus. And this is an actual phenomenon that has been seen in the attempts to make an efficacious vaccine against dengue virus. So it's clear that in the immune activation can be both advantageous and potentially detrimental, and has to be titrated properly to find the optimal balance between immune and inflammatory activation to establish an acceptable risk-benefit profile for a given vaccine. Okay, so I have a few what I call odds and ends, because they kind of don't fit into either of the categories of that I already spoke about. So one thing that I want to talk about is that there is no evidence out there that the virus was created in a lab and or released from a lab. So all the sequencing that has been done of these viral genomes, and there has been a lot of sequencing done, shows that the virus is highly related to a virus that exists in bats. And so that seems not to be true. Every time a virus replicates, especially RNA viruses, there are small changes in the viral RNA sequence. These changes lead to new isolates and not new strains, right? So if you hear stories about there's a new strain, that's not true. A new strain is an isolate that has a different biological property, such as binding to a different receptor. And so far, there appears to be only one strain of SARS-CoV-2, and there is no evidence that it was synthesized, as I said, or released from a lab. Okay. Another topic that I wanted to touch on for a second is whether old vaccines for other pathogens could protect against COVID-19. So last time someone did ask about the use of the BCG vaccine to prevent COVID. The BCG vaccine is used in some countries where tuberculosis is endemic. To prevent TB infections is generally given to young children. And the general reasoning behind the use of either the BCG, and I'll talk a little bit about the use of oral polio vaccine in the same way, is that both of these vaccines are live strains that are attenuated, meaning they still replicate, but they don't cause disease. And the idea is that these live attenuated vaccines seem to boost people's immune system's first line of defense, the innate defense, in a general way to guard against infection from completely unrelated bugs. So there's a study going on in the United States that aims to enroll about 1,800 people, starting with frontline healthcare workers in Boston, LA, and in Texas. There's also a Dutch group looking to administer the BCG vaccine or placebo to about 3,500 people in 2 trials, one involving doctors and nurses and another with elderly subjects. And although it has been observed that some countries are doing relatively well keeping the coronavirus in check, for example, in East Asia and Eastern Europe, where BCG is a standard part of children's vaccination regime, not every country fits this theory because Brazil, which also uses the BCG vaccine, has a very rapid spread of COVID-19. The other is the proposal to use the oral polio vaccine as a general immune booster. And this is based on a paper done in the 1970s by a Soviet scientist who published research showing that flu cases dropped markedly after oral polio vaccination. Now, the son of the author followed in his mother's footsteps, and he's a vaccine specialist at the FDA. And he's seeking funding along with Bob Gallo, who's famous because of all of his work on HIV, and he's now at the Global Virus Network, and they're looking to see if they could obtain funding to see if oral polio virus could boost the immune system enough to prevent COVID. And then I wanted to make you aware of 2 initiatives that are functioning to get us ready for the next pandemic without knowing in advance what it will be. CEPI, or the Coalition for Epidemic Preparedness, was founded in 2017, actually came out of the Davos meeting, as an innovative global partnership between private, public, and philanthropic groups, working together to accelerate the development of vaccines against emerging infectious diseases and enabling equitable access to these vaccines for populations during outbreaks. So again, this is being an organization that's trying to be proactive, monitoring what's going on in the world and having things ready to go in case something happens. And the other is the flip side. You know, the first one is CEPI's about vaccines. READY, Rapidly Emerging Antiviral Drug Development Initiative, is a brand new initiative coming out of the University of North Carolina, the goal of which is to discover and develop drugs to put on the shelf. Again, if something happens, you can pull something off the shelf that might kind of be good for, you know, whatever is out there. So both of these organizations are trying to anticipate future epidemics. And finally, I'm going to leave you again with, as I did last time, how will this end? So every day, and that includes today, I read and hear about new things being advanced to prevent and treat COVID-19. I put this picture in because I want to show you that coronaviruses, with their 30,000 nucleotide genome and their very complicated expression pattern, the fact that they make so many different proteins, right, is good news because it means that there are lots of targets for antiviral drugs. And this gives me hope that eventually science, in fact, will prevail. So thank you for your time today. And if you have any questions, please let me know.
Thank you very much. Dr. Madonna, if you want to jump in?
Yeah, I think we should maybe ask some of the questions that are very specific to Dr. Beaton's fantastic talk. It's amazing that the last one was just a few weeks ago, and so much is new since the last time she presented. So let's go to the first one here. Does the antibody test for specifically COVID, is the antibody test for specifically COVID-19 or just coronavirus in general?
Okay, so the ones they're developing are specifically for, the virus name is actually SARS-CoV-2, right? And the other one, there are actually lots of other coronaviruses. So they want them to be, because lots of common colds are actually caused by coronaviruses. So these tests are specifically towards SARS-CoV-2.
Okay, the next one is how available is the monoclonal antibody? Is it currently being used broadly for all frontline workers, as it seems like a pretty good idea?
It's a great idea, but it's still in testing, so it is not broadly being used yet.
Then we have one about the website to check on current IgM tests.
Yeah, I mean, I'll have to look that up. I don't know it off the top of my head, but there are, you can always check at the FDA, to see which tests are approved, right? Because again, there are a lot of tests out there and a lot of them are really not good, right? But they should get better because they're now having to validate with the FDA. So the FDA will either approve them or not. And again, you want to look for high sensitivity tests when you're looking for antibody tests.
Yeah, the next one is, can you please repeat the name of the process of a vaccine making the virus worse?
Oh, that's called antibody dependent enhancement, ADE.
And what percentage of you discussed this for, I think, dengue fever?
Yeah, every single vaccine they've tried to develop for dengue has caused this. It's actually made viral infections worse. So it doesn't happen all the time, but they are concerned about it with this virus.
Yeah, and what is any other diseases that you've seen, like, besides dengue, where we've seen a lot of enhancement?
No, that's the one where it's most talked about.
And we still have no idea yet, obviously, for COVID at this point.
Yeah, actually, I see a question about the MMR vaccine, and
yeah, go ahead.
That's interesting as well because that's a live attenuated vaccine as well, right? So yeah, that could be yes. So that is very similar to what we're talking about before with respect to both BCG and the oral poliovirus vaccine. All of them may enhance people's innate immune response.
And then we have a question that asks the difference between monoclonal antibodies and making spike protein.
Okay, so, spike protein is made by the virus, right? And the antibodies are made in response to a virus, right? So the spike protein, if a cell expresses it, right, will be expressed on its surface, and then, or pieces of it will be brought to the surface by major histocompatibility antigens, and then your immune cells will recognize it, right, and make antibodies against it. And the idea is to make monoclonal antibodies, which are made externally, right? You're not making them. Companies are making them, that will recognize either the spike protein or the receptor and block the virus from binding in some way.
Then we have a question on mask use. So I'm going to hold that one, and that can be asked again because I think after Dr. Lal's talk, that might be a better place for that one. And the last one is, what is considered high sensitivity for
so
an
I think
antibody test?
You're going to want to have very high 90s, very high 90s, right? Because you don't want to have people testing positive when they're not.
Yeah, exactly. We have another one now as they're starting to pop in. Lopinavir, ritonavir, 400 milligram, 100 milligrams twice daily for 14 days plus standard care. Is this new?
Well, it's new in combination with the other things we talked about, right? So we talked about using it in combination as a triple therapy with beta seron, right? And
so the next question is an interesting one, which speaks to more of our day-to-day existence. If someone just sent in a chat about the audio. I'm not sure if anybody else is having trouble with the audio. If someone has recent exposure to someone diagnosed with COVID-19, should they be tested for both infection and antibodies?
Okay, and this is, so if it's just recent exposure, then you should test it for infection because you're not going to produce antibodies for a couple of weeks. So if you've been exposed to someone, just a few days ago, right, you should be tested for antigen and not antibodies. You're not making antibodies yet.
Yeah, I think it's going to depend on what you're planning on doing also, is it a return to work and so forth.
Right. Well, I mean, in either case, right? So if there's recent exposure is you're going to want to be tested for a virus, right? And then 2 weeks later, maybe you can be tested for antibodies.
Right. Right. Okay, that's what we have right now. You can continue to send in your questions. I think, let me just double check and make sure we got everything. Oh, we have one more. We have two more. So is the thought that those who've had BCG or polio vaccine would need a booster to boost immune system?
Yeah, I think
question.
that like back in the in the example I gave you with the oral polio vaccine in Russia, the scientist who is leading it, again, his mother would give him the oral polio vaccine before the start of before the start of every flu season.
Yeah, I have a friend in South Africa who brought up BCG to me probably right at the beginning of this, and that's exactly what we were talking about.
Yeah, the problem with the BCG vaccine, if I could just digress for a second, is that, we use the PPD test for screening for tuberculosis in this country, right? Which is a very simple test. They inject the PPD under your skin, and then in 2 or 3 days you see the negative or positive. If everyone has BCG, that removes that test as being useful because everybody will test PPD positive, and that means everybody will have to have the quantiferon gold test, right? And that's different than just doing a PPD test.
Yeah, that's an interesting point that you make, and something for us all to look forward to as we look ahead.
Right.
But I'm going to hold right there. There's a couple other questions that actually may
be later.
Yeah, we'll try to jump back to them. So next up is Dr. Kim Poirier-Schmidt. Dr. Poirier is an assistant clinical professor at the college, and she spoke to you last time about the ocular manifestations of this infection, and she's going to give us the latest update on that. Dr. Poirier.
Hey, can you guys all hear me okay?
Yes, we can.
Okay,
and you can start sharing your screen when you're ready.
Sure. Okay. Everyone see that okay? We'll get started.
Yes, you're good on our end.
Perfect. All right. Hi, everybody. Good afternoon. Thank you for joining. I'm going to just discuss a few updates on the ocular manifestations of COVID-19. Last time we discussed, I'm going to do a quick review of what we discussed last time, but there has been changes, as Dr. Beaton pointed out. I feel like every day I was reading something new. And of course, in the last week or two, there's been a lot of updates on COVID in the pediatric population. So I'm going to update you guys all on that as well. All right, so just a quick review of last time in the part 2 of our COVID lecture series. So from the literature, it was found, the ocular manifestations of COVID-19, most commonly, patients were presenting with conjunctivitis. And usually that's, a viral conjunctivitis or run-of-the-mill viral-like conjunctivitis, conjunctival hyperemia, chemosis, and epiphora. Typically, what we went through with the evidence or in the literature base found that the ocular manifestations occur typically in symptomatic COVID-19 cases with pneumonia. So typically we wouldn't really see this conjunctivitis unless they were symptomatic and had symptomatic pneumonia as well. Low abundance of virus in the tear and conjunctival secretions have been found. In a couple of studies, there was kind of a low N value, a low amount of patients in the studies. Some coming out of China and also coming out of the United States more recently within the last month as well. So those studies did find that there was really a low risk of virus transmission through ocular secretions. So we weren't finding that it was a mode of contagion, so to speak, through the conjunctiva. So pretty low risk compared to the eye when you're with contagion or spreading it to other people. But now, this is updates. So we're going to make a few updates to that thought. So of course, everything is always changing. We always need to be kind of keeping up to date with the new information that comes out. And I'm sure a lot of you probably have heard about this case study that just came out recently out of Italy. It was published on April 17th of 2020. And this patient was a 65-year-old female, and she actually had traveled from Wuhan, China to Italy on January 23rd of this year. She was admitted to the Italian hospital a few days later, almost a week after she returned from China. She presented with a non-productive cough, sore throat, but she also had a bilateral conjunctivitis. This bilateral conjunctivitis was very persistent. It continued to be very persistent even through day 3. So they decided at around day 3, after she became symptomatic, to start testing her. And they took conjunctival swabs were taken, and also they did nasal swabs of this patient. And they were testing the amount of viral DNA both in the conjunctiva and in her nasal swabs. And they took these tests, the swabs, almost daily for about 30 days after she presented to the hospital while she was admitted. All right, so this is a table that was excerpted from that one study. So just to kind of go over this table process. So here we have the days from symptom onset, and these were the days that these samples were taken. So for example, on day 3, they took a nasal swab and an ocular swab. And then they also were looking for the viral DNA present in those swabs. And they also correlated with the ocular manifestations. So just kind of putting, just letting you know what these numbers mean. So it kind of isn't, it doesn't really make too much sense. The higher the number, the less amount of viral RNA was in the sample. So they're inversely proportionate to each other. I'm not gonna go into all the details and why that is, just a cycle threshold for viral RNA. Just remember, higher the number, the lower the amount of virus in that sample. And less than 45 here is actually a negative response, or no virus particles found. All right, so bringing that all together, you know, the conjunctivitis in this one patient, it improved at day 15. So went from moderate to mild, and then resolved completely at about day 20 after she was admitted into the hospital. And so the SARS-CoV-2 RNA was detected in ocular swabs when no conjunctivitis was present. So here we had normal, so no conjunctivitis here, but there were still viral particles found in the ocular swab. And this is kind of different than what we previously had thought and what I went over with you guys last time, because the current thought process was that, you know, the patient, they had to be symptomatic, the likely symptomatic, and to have the viral particles present in the conjunctiva. And that really wasn't the case in this one patient. The SARS-CoV-2 RNA was detected in the ocular swabs days after it was undetectable in the nasal swab. So for some reason or another in this patient, the virus was just kind of staying or lingering much longer than in the nasal cavity. So here at day 21, for example, there were no viral particles found in the nasal swab, but even down here in day 27, there was no particles, but there were some viral RNA particles found in the ocular swab. So it's much more persistent in this patient in the eye than the nasal cavity. And also just another note is that there's possible sustained replication in the conjunctiva, which hasn't been shown before in any studies. So just for example here, you know, there were viral particles and there wasn't. And then again, the next time, about a couple days later, when they did test the ocular swab, there were viral particles present again. So there may have been some sort of, you know, viral replication within the conjunctiva in that time, which is definitely new and interesting. It's a new finding at that time. So what are the conclusions of this case study? You know, the case study, it's an N of 1, right? So really only one patient, but it is something to consider, right? This is new information. You know, more studies do need to be performed in order to really get to the bottom of, you know, viral replication in the conjunctiva. But really, this does show that there is questionable replication in the conjunctiva of COVID patients is possible, right? And where there's replication, that means the conjunctiva could possibly be a source of contagion for a patient. So if a patient has recovered from COVID and they had a conjunctivitis, you know, they still could be contagious even after they're asymptomatic. So not only is it a route of entry, it also could be a source of contagion in some patients, in this one patient, of course, but still we can't rule it out completely now. So the study also made note of the importance of PPE, personal protective equipment, and the importance of control measures to protect both ourselves as the route of entry of the virus, and also from preventing the patient from being contagious and, giving us, the doctor that's taking care of them, giving them the virus as well. So I know Dr. Lal will go into a little more detail on PPE control measures, but just know we can't completely rule this out anymore. All right, so just switching gears a little bit. So I know this has been in the media a lot the past week, especially, and the number of cases has been changing daily. We're learning a lot more every day. This is a pediatric multi-system inflammatory disease. Whew, that's a mouthful. All right, so what this is an acute inflammatory illness of children that strikes in previously healthy children. So these are healthy kids, and it's said to be a Kawasaki-like or toxic shock syndrome-like illness. So what Kawasaki is it's an acute inflammation of the medium arteries in a child typically, and it's thought to be after being infected with a virus. So kind of a viral response or viral initiated inflammatory response in kids. Currently in New York, they're actually over now. So there actually was an update today. There's over 100 cases in New York State currently of the pediatric multisystem inflammatory disease and 3 deaths. There was 1 death of a 5-year-old in New York City, a 7-year-old in Westchester County, and then an 18-year-old in Long Island, or on Long Island, apologize. So, there's a really wide range of ages here. So it typically affects kids age 5 to even 18. So a wide age range here. Most of these children tested positive, not all, mind you, but most tested positive for COVID-19 or had antibodies to COVID-19. So they did have a previous exposure to the disease. But again, not all, so we're not 100% sure. It does seem to be a link between COVID-19 infection and the pediatric multisystem inflammatory disease, but it's not fully proven yet, but it does seem to be very highly correlated with that. It's thought to be modulated, the disease inflammatory reaction, by an overreactive immune response. So similarly to what Dr. Beaton was discussing, the cytokine storm. And it's really this overreactive immune response in these children to the viral infection. So things to be aware of, as providers, especially awareness is key. We really need to be aware of this, especially those who are seeing pediatric patients in their practice. It's something that we need to know about, right? So signs and symptoms would be a persistent high fever for at least 4 days. Conjunctivitis was actually one of the common findings of these patients. So, conjunctivitis also, there were some reports of a red eye, just, erythema, edema of the eyelids as well. And the conjunctivitis was actually seen with a possible limbal sparing. And I will show you guys a picture of that in a moment from a case study that was just reported on recently. Erythema and edema of the lips and tongue redness is actually a very common first presentation of this. And also erythema and edema of the lower and upper extremities. A maculopapular rash, and also gastrointestinal upset. So, sore stomachs, vomiting, gastrointestinal irritation as well are very common findings of this disease. And here's photos of this poor little guy here from the case study. So you can see that, there's this maculopapular rash all over their poor little legs here, and they're very swollen, edematous, a lot of redness, and similarly all in their upper extremities here. And this is the photo of the conjunctivitis in this patient. You can see here a lot of kind of injection of the bulbar conjunctiva, and it actually was 360. It wasn't just temporal, so it wasn't really so much an episcleritis, but you can see kind of the limbal sparing here as well. And if we kind of think, with an inflammatory condition, that would also come along with the possibility of, uveitis or any type of ocular inflammation, even a vasculitis. As we know, Kawasaki disease, that there is an inflammation of the artery. So it's very possible that these children may present with other findings that just have not yet been noted in the literature as of yet. So, constantly changing, just really be aware of this. As primary eye care providers, you may come in contact with a child that comes into your office that has a bilateral conjunctivitis, even though it is fairly common, but especially, being in New York City at the epicenter, And we really need to kind of go from there and ask more questions. You know, do they have any other symptoms of pediatric multi-system inflammatory disease? Because the key with this is early intervention. Is as soon as you see any of these signs or symptoms, these kids need to be seen immediately at the hospital. You know, if caught early on, the treatment, they actually respond really well to treatment, and typically they're treated with something called IVIG, and they do respond well. You know, of course, we have those few children here that did pass away, and a lot of the times, you know, we didn't know anything about it at that time. So in some cases, you know, treatment has been delayed because just of not knowing what to do with these patients, or not knowing that this disease exists. So knowledge is power. Just kind of take with this just to be able to ask more questions to any of your pediatric populations that come in with, you know, bilateral conjunctivitis with possible limbal sparing. All right, so this is actually a new study that was released 2 days ago in JAMA Pediatrics. And this study was actually very interesting because it was the first time that we've actually seen in the United States and Canada a study that was outlining what coronavirus disease can actually look like in children. Because up until literally probably a week or two ago, it was thought, or the main thought process was that kids are immune. You know, children aren't affected by coronavirus. We didn't know why, but really, you know, that has not been the case, especially here in, you know, the United States. And this study, the objective was to provide a characterization of COVID-19 infection in North American PICUs. So the study followed 48 COVID-19 positive children, and they were admitted across 46 different North American pediatric ICUs, so both in the United States and Canada. What they found was actually really interesting, but also not surprising. But again, this is the first time we're actually putting into numbers the characteristics of children that present with COVID-19. 83% of these children had pre-existing underlying medical conditions. And again, these children are in the ICU, right? So we know that these children are very ill, and they wanted to know what common features of these very ill patients, what did they have that was common? And they found that 83% had pre-existing underlying conditions, and that included heart disease, developmental delay, diabetes, immune compromise, malignancy, obesity, post-transplant, and tracheostomy. So, you know, a whole host of underlying medical conditions that made these children much more susceptible to becoming much more ill with a COVID-19 infection. And 73% of these children presented with respiratory symptoms, and 38% required invasive ventilation, and the mortality rate was 4.2%, which is actually pretty high. You know, it's about 8 patients within that 48 patient number. So that's, you know, a lot of children that passed away just in that small cohort when you think of it in numbers. So the conclusions of this study was that, you know, severe illness in children is significant. So it does happen. Children can get ill from COVID, but it is far less frequent than in adults. And so I just wanted to throw that out there again, and also back to the pediatric multi-system inflammatory disease, that it is rare, right? So we're hearing about it a lot. Although it's rare, the results can be devastating, right? Even if, you know, 1 or 2 children become very ill, that we need to know about this to prevent them from having even more severe illness, right? So again, knowledge is power. Again, it's much less frequent in children, but again, severe illness can happen. You know, kids aren't all immune. Pre-hospitalization comorbidities, a very important factor in severe illness. And really why that, you know, throwing back to optometry and why that's important for us as eye care providers is that, you know, when we're starting to open up to see routine care patients, we need to be considering now, you know, what high-risk children, you know, children, they're coming in, you know, maybe we should be asking more questions about their medical history before we have children come in for a comprehensive eye exam, right? We need to kind of weigh the risks and the benefits, similarly that we have been doing with our adult patients, right? So, you know, are these children at a higher risk of developing more severe illness if COVID is contracted? So something to take into consideration now, and now we do have some data to support that. I just wanted to bring your attention to a new study that is currently enrolling. It's NIH funded. They're currently enrolling about 6,000 patients from about 2,000 families, but these are families that are already participating in other NIH funded studies. This is the Human Epidemiology in Response to SARS-CoV-2, or the HEROES study. HEROES, much easier to say. So the purpose of this study is to determine rate of novel coronavirus infection in children and family members. So now that we know that COVID can affect children, we want to know, okay, what is the rate? How is this affecting our children in the United States? And I also want to know the percent of children that are actually infected with SARS-CoV-2. How many of those children actually will go on to develop symptoms of the disease? And they also want to know if the infection rate differs between children with asthma, so, a pre-existing lung condition, or other allergic conditions. So, we think that those children who are allergic have an overactive immune response to begin with to different antigens. So, it's possible that children who have higher allergic rates might actually respond differently if infected with the SARS-CoV-2. So maybe their immune system will react differently. And they want to compare that versus those children without asthma or other allergic conditions.
I'm so sorry to interrupt you, but for some reason, I'm not sure if it's your connection, but it's starting to crack a bit. I wasn't sure if it was just me.
Oh. Let me know. I can switch. It might be because I'm on my my AirPods.
I'm sorry.
But... Oh, I'll switch off my AirPods maybe. That could be
okay.
It. I'm almost done. I have one slide yet. Can you still hear me okay?
Okay. It was just really starting to get really hard to hear you.
Oh, sorry about that. Here, I can switch it off. One moment. Technical difficulties, just bear with me.
Okay.
Is that any better? Is that okay?
A little bit, yeah. It could be, are you, okay.
Yeah, I don't know why it's doing that. I'll be really quick this last slide, and then we'll, if anything, if you guys have any other questions, or if you couldn't hear me, I'm more than happy to speak with you guys after too.
I think it sounds fine now. Yeah.
I think it sounds fine now, so we're good. So you're good.
Might have been my slowly dying AirPods then. I apologize.
It's okay. You're good.
All right, so in conclusion, what considerations do we need to take as optometrists? Really the thing that we have to consider is, one, there is possible transmission via the conjunctiva. So maybe there is active viral replication in the conjunctiva that we didn't know about before in patients who are infected with COVID-19. And that's kind of scary in some ways because, what that one case study was showing is that patients can be asymptomatic and not have a conjunctivitis and still have viral particles or viral RNA in their tear, in their conjunctival secretion. But, taking that one case study and kind of melding it with all of the other evidence-based ocular manifestations that I was discussing with you guys last time, is that overall there seems to be a low abundance of the virus in tear and conjunctival secretions. And overall, just based on the current literature, there's low risk of virus transmission through ocular secretions. However, since this case study has come out of Italy, the risk cannot be completely ruled out. It's still possible that, the virus can be transmitted through ocular secretions. That's something new to consider. So COVID-19 in children, your pediatric multisystem inflammatory disease, really the biggest thing here is just be in the know, what to look out for. These patients could possibly present to your office with the conjunctivitis, with possible limbal sparing. That can also set off more questions to ask the patient and their parents if they have any of the other symptoms that go along with the pediatric multisystem inflammatory disease. And also children can become very sick from COVID-19. This is something we didn't know, but now we have some evidence to back that up, right? So these kids that have underlying comorbidities, we really need to make sure we are protecting our children that do have these underlying comorbidities. And really, especially when we're opening up our practices soon, and to take that in consideration and making sure that we're screening our children much more to kind of weigh the risks versus benefits of them coming in, especially in New York City or even in New York State, right, where the numbers are still so astronomically high of new infections per day. And really the next thing is to PPE while examining patients. So protect ourselves and also to decrease the patient risk, right? So we don't want our patients to get sick as well from coming in for an eye exam. So I'm going to throw it over to Dr. Lal, who will discuss this in more detail, but just kind of more new things to consider when we're opening up our practice to protect ourselves and our patients.
Thank you, Dr. Poirier. Before you go away, and I'm going to try to get to a couple of the questions that were germane to your talk and to Dr. Beaton's. And I think some of the questions that have come in probably can jump over to Dr. Lal, including one of the ones that just came in on the chat too. So the first one is, any difference in ocular manifestations between SARS-CoV-1 and SARS-CoV-2? And that's an interesting one to me. I don't remember because we didn't see much of it.
Yeah, so that's actually a really good question. So the first initial larger study that came out of China, that actually was testing both SARS-CoV-1 and SARS-CoV-2 viral particles in the actual conjunctiva and tear secretions, but they didn't find any difference between those two, SARS-CoV-1 and 2. That was just, the one study, I think, with 38 patients. However, the one study that we went through, just that one case study, the more new study, so to speak, that was just testing SARS-CoV-2 specifically. So really the only one I know of, they usually don't test the differences between the two, but now mostly it's concentrating on SARS-CoV-2, and there hasn't really been noted much difference between the ocular manifestations of the two, though. It's a good question.
The next question I assume is looking at the N=1 study.
Yes.
Could they have been measuring dead virus versus replicating virus?
So the test that they use, the viral replication test that they have, so it actually has to be live virus in order to replicate during their test. So essentially the way they test for the viral RNA is that they take the swab and then they replicate it. So say, for example, it might take 38 replication cycles in order to get enough viral particles to, immunofluoresce that test to get actual positive test. So in order for them to actually, be able to get some sort of positive test, there had to have been live viral particles replicating, if that makes sense. So they would have had to have been testing or measuring live virus.
And then the next question goes to any known cases of conjunctivitis without other systemic symptoms.
So out of all of the literature that I've read, there hasn't been any conjunctivitis that was completely connected with coronavirus and without systemic symptoms. So most of them did have symptoms at one point. That one case study that came out, the new thing about that was that the patient still had viral RNA particles in after they weren't symptomatic. So the conjunctivitis was always seemed to be hand in hand with a symptomatic patient, but we're finding that might not be the case.
And you wonder how many conjunctivitis were out there, but because they didn't have systemic symptoms, maybe they never showed up.
Right, and that's always not pulling that out. It's
we're never going to know that.
Yep, exactly.
This one, I'll just continue with you. How long does the virus stay infectious in the tears?
So it's really still unknown. So there's kind of refuting studies. So one of the more recent study that came out last month, I believe the American Academy of Optometry, so AAO, also posted this as well. They found that there really was no virus at all in the tears in their patients. They tested, I think, 17 different patients. But now, with this other study out of Italy with the N=1, it tended to stay in the tears for up to 30 days. So it kind of is all over the place. So it's, we don't really know for sure.
Yeah, more to come, I think.
Mm-hmm.
There's one here for Dr. Beaton. If you wanted to get tested for antibodies, which test is the most reliable at this time? Can we answer that?
Yeah, so I was just looking, so Bio-Rad's test is showing up to be 98% sensitive. Roche's test, which is an electrochemiluminescent immunoassay, so not one of those flow tests, you're not going to get like a pregnancy test readout, says after 2 weeks it's 100% sensitive, so that looks good. So again, I recommend looking at this Center for Health Security .org site. It has a big chart of all the tests. If you're interested and you're being offered an antibody test, you might want to cross-check with that.
Great, thank you, Dr. Beaton. We have a number of others, and we will get to them. Some of them are certainly more specific to the talk that you're about to hear from Dr. Lal. So let's hold on those because we have some great questions about masks and return to practice and so forth. And we'll turn this over now to, I'll let Betsy pull up the slide, to Dr. Anu Lal, who is an assistant clinical professor at SUNY. He is amongst many other things, he's the chairman of our infectious disease, environmental safety and infection control committee. That took a second. And he's leading our efforts to keep our patients safe, keep our doctors safe, and return to practice. So Dr. Lal.
Great. Thank you so much. So I'm gonna go ahead and share my screen here. Very good. And then please let me know when you guys can see that.
We can see your slides and hear you loud and clear.
Great, thank you so much. So, thank you so much for inviting me back to the prom as well. I'm glad we can talk again. So, since the last 2 weeks, since our last COVID seminar, really what I've been doing and what we've been doing at the college now is chatting about the idea of reopening. As you know, the shelter in place in New York is likely going to expire in the next couple weeks or within the next month. In other places in the country, that shelter in place order has already expired. So as we start getting back to our optometric practices, the question is, how do we do this? What do we do, to keep our patients safe, keep us safe? What game plans do we have as we move forward? This is obviously very timely and very particular to us because, again, we're on the front lines, and unfortunately there's a lot of risk involved. Many of you have seen this. This was in the New York Times about a month or so ago. And when it comes to risk of any type of infection, as you can see, there's a scale here that goes over how close you are exposure to disease on the y-axis, here on the x-axis, your proximity to others, where nurses, of course, have a pretty high exposure rate to diseases, and they are relatively close to a lot of patients, versus loggers on the other end, it's actually quite low. For optometrists, where do we fall? Well, definitely we may not be as high in terms of exposure to disease. However, our proximity to patients is very high. And that being said, unfortunately, we can be a vector for transmission. And then that's one of the things that we have to think about as we move forward in reopening our practice in the era of COVID, because this, of course, has changed everything in terms of how we practice. So in the past few weeks, I've been listening to different webinars, looking at sources from the Academy of Ophthalmology, the Academy of Optometry, the AOA, CDC, and I've been involved in a lot of meetings. And from what I get from all of these, meetings and webinars and such, is that as we reopen, the first thing that we need to do is have a game plan. And it's a multi-layered game plan. So it includes things like office setup, patient flow, our exam protocols, our cleaning protocols. And it is something that it's not static. We have to, look at this over and over again. We have to review over and over again. With every of these webinars and these seminars have really instilled in me is that, we have to start slow, and then we need to continue to sort of ramp up. There's no way that we're going to be practicing optometry as we did pre-COVID. So what I'm going to chat about here is I'll start with the first step, which is office setup, right? And I want you to sort of think about these considerations. So, the idea here is that we want to maintain some social distance. We want to make sure that our patients are, even when they're in our practice, they are practicing some social distance. We're not making a petri dish in our office. So what ways can we ensure that we're not making a petri dish in our office? So one way to think about it is, walking through your office, determining possible bottleneck areas. So which areas where patients tend to coagulate? What things can we do to prevent that from happening? I want to make sure that everybody thinks about reducing interpatient contact. I think that's very important because we've been told, obviously, to shelter in place and stay at home because we don't want people, in contact with each other. Similarly, in our office, we don't want patients to contact other patients. So what areas of potential interpatient contact? Can we reduce the amount of time that any one patient is in contact either with us or our staff? That being said, that might mean how we streamline our examination process, how we bring patients directly into examination rooms, how doing only the tests that we need to do to get patients in or out. The longer somebody is in our office, the greater the risk of exposure, the greater the risk of passing on, COVID should a patient have something like that. Other things to consider: what extra precautions do we need to take for our vulnerable populations? So within your practices, something that you need to think about. So your patients who may have COPD, or your patients who are, a lot older, that could be as simple as maybe having, senior hours from, 7 in the morning until 8. Or your patient who is undergoing chemotherapy and has COPD, that you see them on an off-hour time. You come in on a Sunday at 11 o'clock and you see them. That's the only patient you see that day because you're taking an extra precaution for that particular vulnerable patient. And then how do we handle early patients, late patients? Some of our patients may come 3 hours earlier to their examination. Do we really want them sitting in a waiting room for 3 hours? It might be one of those things where we send our patients away, tell them, hey, we're going to call you when we're ready to take you back. Because again, we want to reduce the amount of time each individual patient is in our examination space. So things to consider. I kind of mentioned this the last time, limiting our entrances. So if you have a practice that has multiple entrances, you want to control the flow into your clinic space. So that might mean limiting the entrance. So signage on the front door, telling the patient that, come around the other side, for example. And I've seen this in my local CVS where they're only allowing people coming in one entrance and potentially going out a different entrance. So that's that consideration of one-way traffic. You might have seen that in grocery stores now. There's certain aisles that are going up, certain aisles that are going down. Again, we're trying to reduce areas of cluster. That's the idea. We may have patients wait outside. Again, depending on your practice, this might be like the Target, where there's outside of the Target, there's every 6 feet, there's a little hash mark and people stand out there. And when you're ready to take them, you go ahead and bring them in, again, instead of sitting in your examination space or in your waiting rooms. Again, being exposed to your staff and other people in your clinic. Hand sanitizers, we've installed hand sanitizers outside of our elevators, right in our front doors. We're looking to install more hand sanitizers, encouraging patients to hand sanitize as they come in. I think that's something to talk about. We've talked about this briefly the last time as well, but setting up a COVID pre-screening station, asking our patients certain questions. So have you had a fever in the last 72 hours? Loss of taste, loss of smell, GI dysfunction, all of those type of things you may want to talk to your patients about prior to. That might be something that you do on the phone when they make the appointment. That might be something that you do when they come back, when they actually show up to your practice. So, there is actually redundancy within the system, and that way we're making sure we catch all of our patients. Letting your patients know that when they come into your practice, they do need to be wearing a face covering. And if they do not have a face covering, you provide your patient with a face covering. I think in New York State and New Jersey, that's something of a requirement. And almost every space that I've seen thus far now has a requirement for face coverings. How about things like your waiting area? So have a look at your waiting area. That might mean removing certain chairs. One of my friends who practices at the Moorfields Hospital in London, he showed me a picture of the waiting room. And in the waiting room, there's less than a quarter of the number of chairs, and each chair is about 6 feet apart. Or at least putting up some signage so that patients don't sit very close together. Remove everything from your waiting areas that could come in contact with the patient. So that could be, books, magazines, coffee stations, toys, making sure that you remove anything that a patient could touch. We don't want patients touching things when they get into the into your clinic space. Having some signage or tape on the floors is something that we just ordered in. I had a meeting with the ESA committee this morning, and we ordered things like little taped on signs that we can put on the floors to designate 6 feet. So as patients are moving through our spaces, they're still practicing social distance. Staffing stations, again, something to consider. Can your staff practice social distance? So, is your setup right now where your front desk staff, they're all, 3 of them are sitting side by side by side? Can we space them out? Can we move a front desk staff person to a different area of your clinic? And as I mentioned before, this one-way traffic where your check-in person, you have the other person might be a checkout person. You might set up a desk on another end of your clinic space, and patients leave through that other desk, so they're not walking back over to the check-in area and again getting in contact with potentially other people. We've ordered some plexiglass. So you might have seen this in grocery stores now to protect the cashiers. There's some plexiglass between the the patron and the worker. Same idea. Our clinic space, even though it's a lot of open space, we're now thinking of adding plexiglass areas for patient and staff protection. Minimizing your staffing, so what can be done off-site, so whether that be checking insurances and other things like that, having a rotating schedule so that again we are not bringing everybody every single day to our clinic space, because every single body, every single person could be a vector for the disease. In terms of face masks, offering face masks to our staff as well. And in terms of what face masks, that may vary depending on their role. So your front desk staff may have, a surgical mask on, but if you have an office manager and they're sitting in a back office, a reusable cloth face mask might be appropriate because they're not getting in contact with any patients. So again, that might vary depending on your clinical space. So let's talk about patient flow a little bit. Triaging, really deciding what patients need to be seen. And that's something that you will have to work out through your office. In the past couple of months, although SUNY we haven't closed, we've been open for just urgent appointments only. But for the past 2 months, we pushed off some of, my glaucoma patients. I tend to see a lot of glaucoma patients. So we pushed off some of these glaucoma patients. And every single time I think about when I schedule a patient, my thoughts are, what is their risk for vision loss compared to what is their risk of death, from contracting the virus? The majority of my patients are quite old. As Dr. Poirier mentioned, though, we may have to start thinking about, comorbidities, even of our younger patients. And that's the other point that I put on here. Consider the patient's health. What their occupation is like. So our patients who are young, but they have, COPD or diabetes, vascular diseases, unfortunately, those folks are hit quite hard. What their occupations are. If your patient works in a nursing home, what is their risk of coming to your office and then potentially going to a nursing home and infecting people? And what their living arrangements are. Are they taking care of an elderly patient? Are they, do they have a newborn at home? I don't know. These are things that we have to consider when we reschedule our patients, into our office. Every single time a patient comes to our office, there's risks involved. All we can do is hopefully reduce the risk as much as possible. Consider postponing visits that may need multiple visits. So whether it be like an RGP fit or a myopia control or whatever it may be, where there's multiple patient visits, you may want to consider holding off on that for now. And again, that does vary, per patient, because if you think about it, I mean, there are certain cases where patients do need to come on in. So your severe keratoconic, maybe, they might be needing to be, be seen to get their RGPs fit. So it really depends. In terms of your schedule, obviously, start off slow. So it's going to start off with a very reduced schedule. That will give you time to see how the flow goes. It'll give you time to clean up the examination rooms and clean up all the spaces that you need to clean up. And then as you and your staff get a little more comfortable with the flow, we can always ramp that up. Other methods to help with patient flow is, as you see here, the staff or your technician might be performing brief histories over the phone, doing COVID questionnaires over the phone, and even histories that we may consider to do over the phone as well. And I'll talk about that here in a moment. One thing that you should do is, as you develop these protocols, and that's something that we're developing, at the college as well, we hope to have a quote unquote reopening handbook. So that being said, as you develop those protocols, you may want to relay that information to your patients. Your patients want to know what measures that you're taking to keep them safe. So whether that be something you mail to them, email to them, and also over the phone, that when they come in, hey, your exam is going to be a little different as compared to what you're used to. This is what we're doing. This is why we're doing it. And I think your patients would appreciate the heads up before they come into the practice. So they know that, hey, you know what, they're going to be stopped at the door. We're not going to maybe let them in until you're ready to see them. So they're prepared to maybe, stand outside, or, one of the sort of jokes in terms of practice would be, their car now is their waiting room. You know what I mean? So you're only allowing the patient in when you're ready for them. In terms of arrival, as I mentioned before, you want to control the flow. So that might mean having your staff member direct the flow. So the patients may need to wait outside. You should tell your patients to only bring companions if necessary. So the less people in your clinical space, the better. That's it's a less body, one less vector for the virus. So, some of those patients or those companions may need to wait outside. We may have to send people at SUNY to Bryant Park to wait. And then when their mother is ready to be picked up, then they come back into the college. Screening stations, I already talked about a screening station, but making sure that they know that they're going to go through a screening process prior to going up. In terms of check-in, anything we can do virtually, do virtually. So if it is possible to get insurance information over the phone, maybe patients can take photos of their front and back of their driver's licenses and and their insurance cards. And if you have a secure email that you can use, or if your EHR, even better, if your EHR allows you to send emails back and forth to your patient, that might be the best way to go. If your insurances are verified ahead of time, I think you're gonna be ahead of the game, because I think that'll also help your checkout process as well. So that if your patient, once you finish the examination with them, you can take them right out and they're gone, versus trying to fiddle with payments and other things like that. If possible, use electronic payments like Venmo, PayPal. There's a lot of different types of electronic modalities out there. It's of course better than exchanging physical credit card, and also probably physically, coins and dollar bills. So if it is possible, do something like that. I would recommend that follow-up appointments be made over the phone if possible. So that way your patient does not have to touch base with another person before they check out, because every single person interaction is a connection point. So if we can split that up, if we can break that, so that as you're walking the patient out saying, Julie is going to call you right now to make your follow-up appointment, so that as the patient is standing outside or sitting in their car, they're talking to your staff member and making that follow-up appointment. Anything you can, send them electronically. We already send in medication RXs electronically. Can we do the same things? Can we email our patients their spec RX, their contact lens RX? And should they purchase something within our clinical practice, we arrange it. So we put whatever it is in a bag, whether it be solutions and lid scrubs or whatever it may be, and then we drop it off for the patient at the door, and then they grab it. I mean, that's kind of the way Domino's Pizza is working right now, where they knock on my door and the gentleman took 6 steps back or 10 steps back and left the pizza on the doorstep, and I picked it up and he walked away. So it's a contactless type of delivery and pickup. You may want to, if your EHR allows this, you may want to consider logging the amount of time your patient has spent in your office. This might be useful for contact tracing, you know, as best as we can. Obviously, we try to prevent these type of things from happening, but there may be a situation where a patient with COVID may end up in your practice, or they might call your practice, you know, a week later saying, hey, you know, I've been diagnosed with the coronavirus, and you know, I was in your office a week ago. That way, you know who was in the office at the time, inform all your staff members, and inform patients to, you know, for contact tracing. So in terms of your examination, so let's kind of move on here. You know, I think your exam is going to be very different as opposed to how it has been in the past. I think we're going to rely on technology a lot more. I think we're going to have patients fill out things like the chief complaint and the HPIs and the review systems prior to, and that's going to get uploaded to your EHR systems. So that's something, of course, that I think that we're all working on. In the time being, if that's not possible, things that I've heard other doctors doing is they're seating patients within the examination room. Almost every patient I know has a cell phone. So we said, all right, Mr. Jones, you know, sit over here. We're going to give you a call from the other room, and you perform a history while you're sitting in the other room and you're typing away on the EHR system, and your patient is literally in the room next door. But at least that way you're maintaining social distance. You're a little further away from your patient. So you're minimizing the amount of time that you guys are, you know, within inches of each other's faces. If you can't do something like that, you know, considering standing as far away from the door as possible. You know, when I do my patient education, you know, recently, what I've been doing is either standing at the door or, you know, sitting in a stool that is actually in the door frame. So I am a lot further away from the patient. So the only time I'm very close to the patient is during my examination portion only. In terms of testing and exam elements, as I said before, you definitely want to only do testing that's necessary for the examination. You know, as of right now, you know, routine exams are not really happening. I'm not sure exactly when that's going to happen, whether it's a, you know, 2 weeks from now, 2 months from now, whenever that tends to happen. So as of right now, I would encourage, as we do examinations, really do examinations of what's absolutely necessary to do so. You know, that may change, like I said, in the near future. Only get close to your patient when performing an examination. So I do tell my patients, if I'm standing in the doorway, that I'm saying, all right, I'm going to start the examination portion now. And I do have patients not talk during the examination portion. I mentioned to them, for your safety and mine, let's go ahead and not talk during this portion of the examination. If possible, keeping patients into one examination room. If it's a multi-doctor practice, you may consider, you know, specific doctors and specific technicians to be assigned a specific room, so that they're also not moving from room to room to room, potentially spreading the virus that way. So if we can isolate as much as possible, that's probably the best thing to do. As Dr. Poirier mentioned, you know, there's still a lot of uncertainty in terms of the level of virus within the tiers. So as of right now, you know, at the college, we've decided to avoid the non-contact tonometry. We don't know how much aerosolization happens during non-contact tonometry. We don't know how much viral load gets expelled, if any, during non-contact tonometry. So what we've you know, made a decision to do, at least as of right now, is to avoid the non-contact tonometry. You know, we're doing things like eye care. I do things like Goldman as well, but those are the two methods that I'm doing a lot more often, and we're avoiding the NCT until we find out more. When you are seeing patients, you may want to consider virtual follow-ups. So for example, you're a patient who has corneal abrasion and you prescribe them erythromycin ointment. Your follow-up appointment could be a 3-day virtual follow-up and saying, hey, how are you doing? How's your eye feeling? And then you can direct them on how either they should continue or discontinue the medications or adjust their medications. And you know, you can make a judgment call on, does this patient need to come back in, or hey, you know what, things look like they're healing up nicely, you're in good shape, you know, discontinue the medication in 5 days, and then I'll see you again for your routine. So utilize the technology as much as possible. Briefly, in terms of PPE, this is what we're doing in the college. So all of our doctors, our residents are wearing surgical face masks. We're using either a visor or goggles to protect our eyes. So areas of potential exposure or entry of the virus is your nose, your mouth, and your eyes. So we're covering up on all of those fronts. Gloves, as Dr. Poirier mentioned before, we've ordered slit lamp breath shields, and we have about 25 of them now. We have another 50 on order. And then we have been seeing things like 4-opter shields and BIO shields. That's something that I believe we got a couple, or we ordered a couple of 4-opter shields, we ordered a couple of BIO shields that should be coming in. We're going to play with that and see how it goes. But there are other types of barriers out there that we're evaluating as well. Right now, the only thing that we implemented in our clinic spaces are the slit lamp breath shields. On your patients who have suspected COVID or confirmed COVID, and we've had a couple of them, in those cases, that's where docs, don up in the N95, the caps, gowns. We do have a limited supply of those type of things. And as you can imagine, it's really tough to get a lot of those right now. So that being said, we're only reserving those N95s, caps, gowns on suspected or confirmed cases of COVID. If it's an active infection and the patient absolutely needs to be seen, we do have an isolation room within the lobby of our the college. So you may want to designate a certain room. When I was at Hopkins, we had that's when the Ebola crisis was popping up, and we actually had a designated Ebola room. And me, as the infection control guy, I was the guy that got fit for the N95. I had the full, looks like spacesuit. That's what I had, in case I needed to see a patient with suspected Ebola. When it comes to your donning and doffing your PPE, you got to make sure that you do it appropriately. So you got to make sure that the PPE fits you well, and that includes your N95 masks. And also you've follow the proper protocol for putting it on and taking it off. If you are not sure of it, the CDC has a great website, and the Academy of Optometry website, and I'll show that to you here in a moment. There was a webinar, I believe last week, Andrew Mick from the VA demonstrated how to put on and take off PPE appropriately. In terms of cleaning protocols, I just want to bring this up here. Always think about any sort of office space that somebody can touch and have a disinfectant checklist. So doorknobs, railings, the floors, any flat surfaces, so tabletops, patient bathrooms. And this will vary per your practice. It'll vary on how many patients you see per day. You do want to set up a disinfection schedule so that there is somebody assigned to do that disinfection. And like I said before, the frequency is based on patient volume. So we've been doing at the college every 2 hours. So right now, every 2 hours, we have our facilities team that's cleaning our lobby area, the elevators, and all the waiting rooms and the examination rooms, the bathrooms and such. As we ramp up clinical care, we may need to increase the volume of that cleaning schedule. So that's going to vary per your practice. Specialized testing, I do want to say that at this point, we're trying to avoid as much specialized testing as possible, but there are cases where we need to do specialized testing. My glaucoma patients in particular, I need to do some sort of specialized testing to ensure that things are stable for our patients. Many of the companies now, so if you go into the Zeiss website, or you go to the Topcon, or Hogstrite website, they do have cleaning protocols for all of their equipment. I do encourage you to look at that. Most of the equipment, they recommend in a 70% alcohol solution, but I would recommend you to look at their websites. There are certain types of spritzers and such that they require to prevent any damage to the equipment. So it is something that you really need to touch base on. The other thing to consider is, airflow within your testing rooms. It is one of those things where a visual field can take time. Your patient could be sitting in there for 10 or 15 minutes. If it's in a small cramped space, this is something to consider, not only for the safety of the patient, but also the safety of your technician running the test. So we may need to, start the test. Your technician might decide to, stand outside with the door open, and then, every so often jumps in to check to make sure the patient is doing okay. After the patient leaves, the Zeiss protocol for a Humphrey visual field is rather extensive. It does take a little bit of time to do. You want to air out that bowl. The patient's been breathing in that bowl for the past 15 minutes. So, you want to make sure that you schedule things appropriately and follow the directions based on the manufacturer's recommendations. This is the same slide I showed you the last time as well. When it comes to what we use to clean our examination rooms, we use either Clorox wipes or Cavi wipes on most of our surfaces. And like I said, in terms of slit lamps and other BIOs and such, we may use alcohol to clean those off, but follow the protocols based on the manufacturers. Think about every single space within that examination room that could be touched or, potentially breathed on by the patient. Always use an agent that is approved, and the EPA does have a whole list of disinfectants that are effective against COVID-2. So it is something that you want to look into and make sure that you're following those protocols. Although many of us, as we open up here, we're not necessarily doing routine care. We're not necessarily, maybe using the optical. However, there are situations where you may need to fit patients on an urgent basis within the optical. Your patient who might be a -12 and this was their only pair of glasses, you may need to fit them in the optical. Or your patient who's a young child who's, let's say, a refractive amblyopia that broke their glasses, they may need to be fit. So I'm just going to go briefly over optical considerations. One thing that you may want to consider is having your optical by appointment only. So people off the street are not necessarily coming in and looking and at your frames. Again, you want to control the flow within your office. In terms of signage, make sure that there is signage within your office, knowing that patients should not just willy-nilly try on frames, or you may need to keep your frames locked. So if you have an open space for your frames, a lot of folks are taking those off and maybe keeping them in locked cabinets so that patients are not touching the frames. Use virtual try-on software when possible. And then, like I said, you're working with an optician, so the optician will be in PPE. They will have, trying on the different frames. All frames that are tried on should go into a cleaning tray. They should not go back onto the display until it's been completely cleaned out. Speaking of PPE for your opticians, they tend to be rather close. There is breath shields now for pupillometers as well, so that it might be something that you may want to look into. You also may want to look into the appropriate cleaning protocol for pupillometers. And I think you should probably go onto the website of the company to check on that as well. Just like before, electronic payments, I think that that's something that we are likely going to move towards in the near future. Contactless pickup when the glasses do come in, or being able to mail the glasses to patients, that's something that we may consider as well. This is definitely a trying time where there's a big change in the way we practice. So before I leave you today, the things I do want to mention is obviously starting slow. Have weekly meetings with your staff. Although you might be sitting in the examination room and you might be thinking that things might be working out smoothly, but your front desk staff or your checkout staff or your patient account staff might have a different story. They might be telling you that, no, we had 6 patients lined up back to back to back. This was a huge bottleneck. It might be something that we need to look into. Reassess your protocols, update them often. Keep up with the resources. So these are some of the resources that I've used for this particular talk and stuff that I have been using. I do want to just show you those resources here really, really quickly. So as I mentioned before, things like, so as I mentioned before, the New York State is fantastic. They do have a whole section on infection prevention protocols. The American Medical Association has a physician's guide to reopening, and it's something that's updated relatively often. This one was updated just a couple of weeks ago there as well. we have things like the CDC is fantastic here as well, and the Academy of Optometry is one that's. Let me see if I can pull that up here for you. So this is the Academy of Optometry. They have a huge COVID hub. So I implore you definitely have a look at this. This is fantastic. In terms of opening up the office and donning and doffing PPE, they do have a webinar on it that was aired last week, so I would recommend you looking at that. They also have, like I said, they have fantastic resources here. So Physician's Guide to Reopening. They also have Responsible Social Distancing. And they do have a synopsis of many of the research studies. So, if you don't have time like Dr. Poirier and Dr. Beaton to really catch up on all those research studies, the Academy has fantastic resources for you. So it is something that you may want to look into. And like I said, this is that outline that I was, where I based a lot of the talk on. So as always, definitely don't hesitate to reach out. I will throw this back to Dr. Madonna and Betsy, and I look forward to your questions.
Okay.
Thank you, Dr. Lal. Yeah, Betsy, I'm just going to jump in. Let's make 5 o'clock a hard stop. So if we have questions left over, perhaps our speakers will be able to answer them electronically. But Dr. Lal, there's a number of questions that speak to NCT, Goldman, which is higher risk, should Tonapen be used, how do you disinfect a Goldman? I think you've had these questions many times in our own institutions, so perhaps you could just address tonometry in general.
Absolutely. So the Academy of Ophthalmology and on the Academy of Optometry website, they do have a little thing that says avoid NCT when possible. So we're trying to avoid the non-contact tonometry. And the reason being, as I mentioned, is that we just don't know yet. We don't know how much or if any the virus aerosolizes, and can that be a source of infection? That being said, I would like to do things that is disposable as much as possible. So the eye care is disposable. We use the disposable tips on the eye care, and I'm able to clean the eye care off with alcohol. When I do use the eye care, I have my mask on, I have goggles on, I do have a visor as well. Even though I'm not getting very close, to the patient, I'm still, not inches away from the patient's face. But that's what I tend to use as of right now. In terms of cleaning your Goldman probe, I can send this out to you, but in terms of cleaning of the Goldman probe, it is something that is a little cumbersome. And what I mean by that is there's usually rinsing involved, about a 15-minute rinse. Then you want to soak the Goldman probe in either 3% hydrogen peroxide solution or a 10% bleach solution. You're going to soak that in for 10 minutes, and then it's going to be a 10-minute rinse and an air dry. That's the appropriate way to disinfect a Goldman probe. If you look at the Goldman probes, if you go to the company website, or if you actually look at the package insert that comes with every single Goldman probe, it says on there, do not clean with alcohol. It voids the warranty. Now, although 70% alcohol does kill the coronavirus, the reason that it says that is that over time, using alcohol can affect the glue that holds that Goldman probe together. So if you want the proper way to clean it, it's going to be a 3% peroxide solution or a bleach solution, and it does take time. It's 15 minutes of rinsing, 10 to 15 minutes of soaking, and another 10 minutes of rinsing. There are disposable Goldman probes, and we have a few in the office as well. So in those cases, I have used disposables, whether it be the Tonomate or the Keeler disposables. But anything I can do disposable, that's what I'm going to do for now until I get more information.
Thank you, Dr. Lal.
Yeah.
There are a lot of questions that have just come in. I do want to make mention, as a few people have mentioned, that the American Optometric Association also has resources on opening the office. I'm not sure if you had mentioned that, as I lost track of a few things, but the AOA also has resources regarding reopening at aoa.org/coronavirus, which would also be useful for reopening your office. I guess there's probably time for one more question, and I'm trying to figure out which one we should go with. I'm going to go with this one. This one could throw out. Are there any, actually, I'm going to ask two questions. This is going to be
Sure.
the first one. Are there any credible case reports on reinfections by now? Dr. Beaton, you want to field that one? If you're still here?
Sure. Yeah, I'm still here. So I think the answer to that is no. So where they have had these reports, they have done the testing by using PCR. And let me emphasize that PCR testing does not look for live virus. It looks for pieces of RNA. So you could have broken fragments, broken viruses, but not replicating viruses. And so it seems like those reports are not factual. Or they're just wrong because they tested it the wrong way. So what they haven't done is actually try to isolate virus, infect cells, and see if they get new virus out of it. All they find are fragments of RNA.
And the last question, which we could throw out to anyone that's probably for or new, there are 5 or 6 like this. Any thoughts on when we may reopen for routine care? Is it okay to have an optical open? There's variety of 5 or 6 questions like that. Dr. Lal, do you have any insight? Yeah,
right.
That's a toughie.
It is, it is. I don't have an inside track to either the governor or Dr. Fauci.
No,
I wish I did, but it is one of these things where obviously we've seen some as we've opened up, as the states have opened up. There is concern of another spike. We've seen that in other countries like Germany and South Korea and Japan, and that might set us back a little bit as well. There is no clear guidelines on what constitutes routine care. So as I mentioned before, if your patient is like a -13 who broke their glasses, can you see that patient? Can you refract that patient? I think you can make an argument that you can. So it is one of these things where unfortunately there is no absolute guidelines. I do continue to watch the Academy web pages and the AOA web pages for guidance, but it is one of those things where it is up in the air at the moment, unfortunately.
Yeah. We have a number of other questions. If our panelists care to answer them electronically, we'd appreciate it, because we've hit 5 o'clock. So I'm going to throw it back to Betsy. But before I do, I just want to thank Drs. Beaton, Poirier-Schmidt, and Lal for their expertise, their time and expertise, and doing this a second time. And who knows, we'll watch what's going on, and we'll be back with a COVID in the optometric community if we feel that there is a need for that. So thank you all for being on. Thank you for the kind words that we've received for the program. That all goes toward our speakers. Thank you. And I'm going to hand it to Betsy.
Thank you, Dr. Madonna. Again, I would like to thank our speakers as well, and our sponsor sponsor Allergan, for allowing us to be able to have this program and put everything together that we're putting together as much as we can. And obviously, everything comes out in very short notice because there's so much information and trying to pick up the right timing for everything. But I just wanted, for those who weren't able to see it earlier, we are having our pediatric symposium May 26th through the 28th. That'll be during afternoon hours, and then we'll repeat the same courses on June 2nd through the 4th during evening hours. That registration will be sent via email tonight at some point. I'm trying to finalize the last little pieces on it, so you'll have that as well. It will also be on our website. Again, I thank you. Slides and recording of today will also be sent via email to you within the next 2 to 3 days, just because we need to make sure that we edit everything accordingly. Have a good night. Stay well, stay healthy, and take care. Bye.